let's go ahead and get started. All right. Hello, everyone, and thanks for joining Data Control 2021. Welcome to the Data Bridge. My name is Corey Fowler, your host, and I'll be co-hosting with Stephen. We'll be moderating the chat and Q&A during the session. Today we have our guests, Maxime Bigot and Ajali said, both from Accenture, and they will be presenting on their session, data-driven solutions for COVID-19 contact tracing and vaccine. Let me introduce you to both our speakers before we started. A little bit about Ajali. She's an SAP Business Intelligence Manager at Accenture. She's a senior manager at Accenture, leading and championing analytics transformation across large organizations. And then also for Mr. Bigot, he is an Augmented Insights Senior Manager at Accenture. Max serves as the Accenture Tableau lead for North America West Market Unit. He spent his 10 years at Accenture focusing on business intelligence, analytics, and anything data. He's built his expertise through several Tableau, Quilk, and Watson deployments across multiple industries, including product, media, and pharma companies. Currently, Max is leading our dashboarding team for the COVID-19 contract tracing program in the state of California. So join me in welcoming both Maxime and Ajali in their presentation regarding building data-driven solutions for COVID-19, contact tracing, and vaccine management.
Thank you, Courtney, for the intro, and Stefan as well for hosting us today. We're happy to do this presentation with my peer, Ajali here. I'll cover first about our contact tracing solution we built for California Public Health, and Ajali will go a little bit deeper on our vaccine management solution. Our mission for the contact tracing program was really to prevent the transmission of COVID-19 for the health of all Californians. And we had three major challenges going in. The first one was people think that contact tracing is new, but it's actually been used multiple times in the past for other communicable diseases such as tuberculosis or AIDS. And the first challenge for us was to really just enable and scale and reuse those tracing efforts that were already existing at the agency and scale that. And so the second challenge was that they didn't have the technology, as per 2021 to actually scale, and respond to a pandemic of that level. So we actually built a platform, based on AWS, and basically enabled a major virtual call center. So that was the big technology challenge there, and we partnered with Salesforce as well to make that happen in weeks rather than months. The third challenge was, as the state started redirecting staff and looking out for local staff to also step in, there was that big pool of resources to build what we call an army, right, of contact tracers and investigators. So I'll dig a little deeper on those tools that are so critical to contact tracing. Case investigators and contact tracers such as Sarah and Mitch. So a case investigator is really the person responsible for picking up the cases. So that's triggered by a positive test to COVID-19. And someone like Sarah will actually contact an infected patient. She'll gather information about the status of her well-being. And additionally, she will get the contact details of everyone she's been in contact with for the past 14 days. From there, it's actually a contact tracer that picks up the work, and someone like Mitch actually contacts and refers any potential exposed people. And they look for, they also refer for places for testing and provide them access with support, additional information such as where can I go get, my groceries, delivered, for instance. We base, contact tracing is efficient with a few assumptions. One is that, the contacts are actually, the contact details are accurate. That the patient are also, allowed and welcome to share some really critical personal identifiable information, such as phone number, email addresses, etc. And also we're really bases our assumption on the fact that we have a better success rate if we can actually contact, if our case investigators can contact the patient by phone and really get in contact with them at first try. Uh, as the program matured, we also used other technologies than phone. We built a virtual agent, and we built some more follow-up functionalities to be more efficient. But the flow of contact tracing is really, you pick up the case, you contact with that infected patient, you collect data about potential contacts we've exposed, then you connect with those contacts. You may be connecting with also businesses or public places where they might have been actually carrying the disease, and so you want to make sure you can try and reach out to most people, whether it was maybe attending a session at a movie theater. Then you want to make sure that you can contact the people who attended, or if it was a local restaurant, you would want to also maybe get a log of the person who ate at the restaurant at that time. And then really it's all about referrals, right? Referral for testing, referral for um, um, groceries, food, access to food and health organization, and then about follow-up, right? So we have built-in scripts in our call center. The first two are critical: case notification and contact tracing, then contact notification and referral. Well, the third one I mentioned, informing businesses and or any other places of exposure. The fourth one is really about symptom monitoring, checking on how contacts are doing during their quarantine. And the fifth one around how symptom monitoring this time for the cases and checking on how they're doing on home isolation. Now, how reporting and analytics actually, help us, run that program and monitor that program. We have three approaches. The first one, which is performance reporting, was really about measuring the effectiveness of the tracing process overall. Second, executive reporting was really about giving that overview of the work being done at two levels: the state level for the, again, California Department of Public Health, it's a state agency, looking at the 58 counties that join. We have 62 state counties in California. 58 of those so far joined the contact tracing program. So it's really about giving that executive view to both the agency, state agency, and the local health jurisdictions. The third approach is advanced analytics, and this is where we're trying to push the envelope and get new insights on the health of citizens. Now looking at work, tracks of work of how we've helped and built-in analytics. First one is operations, very tactical, really looking at the performance of the virtual call center, understanding hour by hour what's the productivity of the contact tracers. Not so much to look at their work productivity per se, but to be able to scale up and down the resources, right? Based on, the surges that happened during the pandemic, really looking at both individual numbers, but also aggregated numbers for agents by local health jurisdiction. Second track of work is local support. How can we really tell a district or a county if they're acting properly, right? And give them the tips of maybe switching the needle a little bit. An example of that is the way counties will deal with contact tracing in the border of, in the south border of California is a bit different than states in the northern, part of the state, especially with how, some of the variants and some of them spreading around Mexico, started coming into the US. So we actually can adapt the messaging of the contact tracing and the techniques and tactics as well. The third one is really about tracing what we call the care cascade. So how do we progress across that, work stream of contacting a case and a patient and a potential contact, right? We will look at how we moving, following up on those case and contacts across what we call the care flow, making sure that we complete, if a case, the end of a case is actually making sure that that person turned out to be testing negative and turn out to not be in contact with other, other people. So we'll look at that, and we're able to define at census level what are maybe the areas that needs the most help, and we stratify that data by age, by race and ethnicity, gender. Those are really the main variables we'll look at. In terms of outcome, we really look at, like I said, the care cascade and how we can support locally. So visualizing that right on the map right there at state level, and again at district level, being able to zoom in and say we're, for this example on the bottom left, we're really looking at how are we doing on our outreach? Have we interviewed, are we interviewing fast, right? Are we interviewing within 24 hours? Or do we need to do more follow-ups? Secondly, we're really also helping epidemiologists identify where the disease transmission is happening, how the infection is spreading. Is it through an outbreak? Is it through a household, being part of a household? And what are the connections also of the variants, right? Lately, that has been taking a lot of attention for us, and really again identifying those areas of maybe greater vulnerability, also introducing the notion of people that are fully vaccinated versus people that maybe are halfway through vaccination and people that are not vaccinated at all. And lastly, what we've been able to do, and we're continuously building upon, is mapping out a network graph representation of how the virus is spreading, just not physically on a map, but also looking at that network graph you have on the bottom right of the screen here. Like I said again, looking at what are those hotspots. And earlier on, during the first surge of COVID, we really looked at congregate settings like houses of workshops, right, churches and jails, because those were places where social distancing was not really possible. Wearing a mask was not really a habit yet, and so that was a lot of focus with the first wave. But more recently, with the reopening of schools, we're actually keeping a close eye on schools outbreak, and making sure that we can um, pass on that information to the LHJs so that they can do very proactive contact tracing. And again, the accent more recently is adding that dimension of vaccination status or not, and that's really kind of a game changer to be able to refocus and prioritize on those populations that are not fully vaccinated yet. And I think that's my segue for Ajali to tell us a bit more about vaccine management.
Thanks, Max. Okay, so I will delve right into vaccine management. So essentially, Accenture partnered with California's Department of Public Health as well as their Department of Technology to essentially set up a data and insights driven response to the COVID-19 pandemic and help the state manage their vaccine distribution, their allocations. So some 5 key areas where we supported in vaccine management was around equitable vaccine distribution. And I will come later in the talk track around how key equity and the equitable distribution of vaccine was as a metric to the state. The second being managing vaccine demand and supply, especially of relevance during the supply constrained periods within the pandemic. Third, managing performance of providers and essentially measuring them on how much inventory they were carrying, what was their rate of their administration, what pockets of the community were they administering the vaccine to, going back to whether they were administering the vaccine equitably. Fourth, we supported the state with various incentive programs that they have launched, especially targeting harder to reach communities or hesitant populations for the vaccination. And finally, we brought our data science and advanced analytics expertise to build vaccine forecast models that essentially showed the state on what were the key kind of milestones when you would hit like 70, 80%, answering the key question that when would we accomplish herd immunity. So if we go to the next slide, the results of having that data-driven approach towards a pandemic response is evident just in the numbers. So just as of today, there are 26 million residents of California. That is around 80% of the adult population that's been has at least received a dose of the vaccine. There are 48 million doses that were administered as part of this solution. California has one of the lowest case rates within US, and this was one of the first states that shut down due to the pandemic in 2020, and it reopened in 6/15, having accomplished a 70% milestone on that date. Moving on, the solution that we essentially deployed was a vaccine management analytics solution, and it was based on 3 key areas of vaccine management: the health equity, the administration of vaccines, and then managing the vaccine supply chain. And with considering these 3 key pillars, the solution that we provided the state allowed both the state, the local health jurisdictions, as well as other health departments get a very detailed level of visibility into vaccines, their administrations, the progress of vaccinations, the communities to which it was being administered. So the 5 areas where we essentially focused on our analytics solution was 1, vaccine allocation, which essentially is that who needs to be allocated X number of vaccines, which sites need the most vaccines. Second, managing vaccine distribution and all the logistics that goes with it. Third, the recording and reporting of vaccine administration. And this was a key area of focus of this state because they publicly report these numbers out every day, and they are accountable for those numbers. Fourth, addressing vaccine equity. Again, another metric that the health department and the local health jurisdictions are accountable for. And fifth, assessing and understanding the community impact for the vaccine. That includes assessing which are the most hesitant populations and what can be done to do outreach into those populations. So going to the next slide, in each of the for each of the areas, I think what I've represented in the slides, and we can move through those fairly quickly, is on allocation. Essentially, the question that we wanted to answer through our reporting is how much vaccine is essentially needed, and then a level of drill down that what type of vaccine is needed, at which site is the vaccine needed, at which location. Is there an oversupply of vaccine to a particular provider? Is there an undersupply of vaccine? And to that end, we built a whole suite of dashboards. We call these performance management dashboards, but it at the detailed granular level of every single provider, like a Kaiser or even a CVS or a Walgreens. And at every single location of these, we could monitor how many vaccines they administered, how many inventory they were holding, how many doses they had wasted, or how many doses of theirs were expired, and what was the throughput at each of these site levels. And all of these were inputs to a dynamic allocation model for us to determine how much allocations of vaccine each site should get. Moving on, the next key pillar was vaccine distribution. This was more around the logistics of the vaccines, like how many shipments of vaccines are inbound, at what point in time will they reach, do each of the providers have sufficient dose 1s to administer, will the dose 2 reach in time, And then again, of course, what is kind of the on-hand vaccines and when are they set to expire? A lot of this was very critical, especially during the supply constrained windows. And these are just some examples where we have talked about week over week, we were measuring how many doses were delivered and essentially measuring those against targets and seeing if there was at any point in time a short supply or an oversupply of vaccines. And all of this reporting was made available not just to the state, but to every individual provider, to local health jurisdictions. So everyone had a lot of transparency into what was getting reported out and what was happening at the ground level. Moving on, the next key pillar, the third one, is around recording and reporting vaccines. And this was probably one of our most critical parts of the analytics solution. So this was really around how many vaccines were being administered, and then a whole set of reporting around day over day vaccine administration throughput, overall for the state, by an LHJ, by a particular provider, and then essentially slicing this data by the various demographic profiles, slicing this data by the different race and ethnicities to see was there a particular quartile that was lagging behind. And quartile essentially was how the state was measuring the healthiness, if you will, of a particular community. There were 4 quartiles, and 1 through 4, 1 being the quartile that has the lowest access to public health, 4 being the ones who had highest access to public health. So all of the reporting that was being done was to ensure that vaccine distribution was equitable across these 4 quartiles. And this is an example of one of the reporting that we stood up, where we essentially measured by site, by location, what was the vaccines that were administered. The one on the left kind of shows how this was distributed across the race and ethnicities, and sometimes even by other cuts like occupation, age, etc. And then a lot of assessment on also clinic capacity, just to ensure that, especially when eligibility opened up mid of April, there was a lot of reporting that went into support that did clinics have enough capacity for population to come in and get vaccinated? How much could they support? What throughput could they support? And then were there certain trends that we were seeing around walk-in versus scheduled appointments? Because walk-ins was essentially unplanned administrations that you were doing without having capacity allocated. So again, a critical analytic solution for the state, again, being made transparent from the highest levels of the government down to the most granular level, which is the clinic manager at a particular clinic doing the administration. The fourth area, health equity. So just to explain the equity, it is evident that not all sections of the society had equal access to healthcare. And this was a great area of concern for the state. And they were accountable for ensuring that the vaccine distribution that happened in an equitable manner. So all sections of the society had equal access to vaccination, and they were progressing at the same pace. So to that end, there was a lot of reporting that was done based on race and ethnicity, measuring like the bar chart that you see above. That's actually publicly available in the state of California's COVID-19 site. And that essentially shows for each race and ethnicity groups, what is the percentage of population that's been fully vaccinated versus partially vaccinated, and what percentage is still unvaccinated. And even with this, the inequity is evident. And the one below essentially shows the percentage vaccinated by quartile, which I just talked about, quartile 1 through 4. And based on this reporting, there were a lot of actionable, a lot of these were actionable insights, and the state took several actions, the incentive program being one of them, but also one of the actions that the state took was essentially organize a lot of mobile clinics, especially in the lower socioeconomic profile areas. Again, with the intent of making the vaccine distribution equitable across the quartiles. And everything that is shown here is actually publicly available for anyone from the general population to go in, and they have a mechanism to respond to questions, respond to inquiries through press briefings or through some of the mainstream reported channels like CNN. Moving on, the last pillar was essentially the measuring the impact of the vaccine on the community. And this is where we developed a lot of reporting to essentially underline hesitancy as one of the factors in the community. Were there particular sections of the society that were more hesitant? What was contributing to the hesitancy? And the other impact was also around the incentive program and the impacts of the incentive programs in vaccine administration. So these are some of the examples. So the one on the right is around hesitancy that was done through a survey. And the one on the left essentially shows the 4 quartiles and how the vaccines have been administered over time into those quartiles. So there was the trend, at least for the past couple of months, has been that we are seeing more quartile 1 and 2, the lower profiles getting more administration than quartile 4. But when vaccination started and when it opened up, it was quartile 4 was at the highest, being the section of society that is most tech savvy and has most access to healthcare. So these were essentially like the 5 pillars on which we set up our solution. What I just want to make sure this audience takes away is also we never forget the human impact of the work that we are doing. And some of it has been shared back with us. These are real people who have shared feedback with the state of California on the vaccination, the reasons why they did it. Like the lady in the middle, she said her 2 little reasons why she got vaccinated. And then some people saying, I took the vaccine and I hugged my elderly mom after 3 months or 4 months, or I got a vaccination and now I can have, essentially I can go meet my friends or, have a birthday. So we never forget that the work that we're doing here impacts people's lives, and as a whole are privileged to be part of analytics-driven solution that has enabled the state to better respond to the pandemic. So that kind of concludes my section. I will open it up for any questions or hand it back to you, Courtney.
All right. Thank you, Ajali. Thank you, Max. I appreciate your presentation. Let's see if there's any questions here in the Q&A. Hopefully, we're going to pull something. I know COVID has definitely been a hot topic over the past 2 data cons we've had. So looks like, Steve, you got one of your own questions in there. And I guess the question we have here is, what are some of the challenges of working with protective health data in this public-private collaboration?
Yeah, I can maybe have a quick go at it. So there are essentially 2 types of data. One is like PII data, and then other data is kind of non-identifiable. So PII stands for personally identifiable data. And there is a lot of restrictions around how PII needs to be handled, reported on. And the state kind of ensures that all contractors to the state, Accenture being one of them, follows those standards. But a lot of reporting that we did was based on non-protected information. And as I mentioned, some of these metrics, especially on equity, they're also publicly available. So a lot of it is aggregated data, aggregated to a county or aggregated to a particular socioeconomic profile. So such data we can share openly, in fact, even publicly. The personally identifiable data there's a lot of restrictions on sharing that. even within the projects that we work on. Having said that, we are always careful, and one of the restrictions that we have on public reporting is that if a particular section that we report on, any level of reporting that we do, if that has less than 11 people, we essentially suppress that data just to ensure, because it is considered, if you have a population of less than 11 in your reporting, that could end up being personally identifiable data. So we apply suppressions to that. So these are some of the measures that we take around just ensuring that at no point we are publicly sharing any kind of PII data. That's on the vaccine management side. Max, I don't know if you want to add on the contact tracing.
Similarly, on contact tracing, I mean, PII is all over the place for us, right? As I mentioned, right? Whether it be a phone number and an email address and a physical address, we do have a lot of that. So we obviously our platform is very secured, and all the analytics and reporting that we do, we actually ensure that we make it at an aggregated level, and that even when we're doing an aggregate, we're making sure that the data cannot be downloaded as the raw data underneath it, so that people could actually rebuild that aggregate and find out, as Ajali alluded, could actually identify if it's a smaller set of data. You could actually kind of try and make up the pieces together. So we're restricted the sharing and downloading of such data. And what we also did on our geomapping visualization is that we made sure to jitter or randomize, if you will, the exact location. In some cases, you could be sharing a person house. It could also be maybe a place. If it's a public place, you also didn't want to be able to easily identify it on the map. So we jetterized that through a specific radius that we agreed with the state would be good enough so that we cannot identify the exact location, but also kind of precise enough so that we can get ideas of like hotspots.
Great. Thank you, Max and Ajali, for that very complete answer. Do we have any other questions from the audience? Please don't be shy. We've got plenty of time.
Please use the chat, use the Q&A function. We're happy to use both of them. I know that it's a great presentation. Again, I've been amazed by each one of the COVID presentations we've had over the past couple of days. So I think that this has kind of been one of these great ways for us to kind of use our collective knowledge of learning how to visualize data, collect data, and really make it useful for us to help our state and help us kind of get through this pandemic. So, if you have any questions, please let us know. We'd love to continue this
A quick.
So
go ahead, Stephen.
Yes. So I'll ask another question. So are you involved in the development of contact tracing apps, and sort of how involved are you? Does your modeling inform those decisions? Or
Yes, there is a program called actually CA Notify, which is part of the Bigot program, and we've been working, collaboratively with them on a weekly basis. They do, we share some reporting together. They've been working with the Apple and the Googles to make sure that the technology is enabled, and they've been, seeing some traction on their own track, right? So it's something that we're definitely plugged in with, but really the bulk of the contact tracing effort, at least for what Accenture was helping with, was really to enable that, what we call that virtual call center and the virtual agent that went with it.
I see. Cool.
A question I often get is really about what was the most exciting exciting part of that journey, and I just want to stress what Ajali actually mentioned, and Courtney as well, is it's the human aspect. Like being consultant, right? We Personally, I've been working for 11 years, right, cross industries for Fortune 500 companies, and we typically focus on growth, right, and financial growth, right, and how you can manage that wealth and making sure that you can keep up. And for once, it was actually good to really see an impact to the community, and eventually actually down the line, we like to think that we're helping saving lives. So it was really touching for me and the whole team to just have that special connection with the Californian citizens, and really be doing data for good.
Yeah, and I'll add to that we had a lot of naturally, there was a group of people from Accenture, and there's a certain culture that we bring in. Of course, extremely motivated and driven. But this is probably one of the programs that I've seen in my career where we had an even more passionate group of stakeholders. And I just wanted to add that the state redeployed a lot of people from different places, and they worked night and day along with us, right? No weekends. Every day, there's like we are running like 16, 17 hour shifts. And these were people from the health department, these were people from the local health jurisdictions, sometimes it was providers. So I think it was a very driven and passionate group, and acknowledging the fact that we were at a historical point in time, and dealing with a human crisis, a global human crisis. So again, I think, as I said, it has been a privilege to work here, but there were, I mean, this was a lot of time and effort from a very large group of people that kind of got us to a point where we are, where we could say that, okay, 80% of the adults are now vaccinated. And we are now on our way to getting digital vaccine records for Californians.
Agreed, and we're working with populations that are may not be tech savvy, right? And they are learning a new language, right? They are not data experts, and we come in, we have our expertise around data, but it's how you can work together and enable this population, and make sure that they feel at ease with the raw data, they feel at ease with the aggregates, that they can trust that data, and become a more data driven organization. And it was incredible to see people like epidemiologists, really stepping in, leveling up their games, and um, and being data, the way they speak now, and putting, like Ajali said, putting the extra hours to just try and solve for this pandemic.
Yeah, actually said something there that was pretty interesting. You mentioned trust, right? What was one way that you really connected with the client on that to really kind of build that trust with their domain knowledge, really help build out this project?
Well, personally, it was with going down to the actually row by row, like looking at the raw data and validating some of those, PhDs, epidemiologists are actually very detail oriented, and analytical, right? So you really kind of, I think, you need to take the time to not just jump to the conclusion of your analysis, but really go back to what is the scope of your data analysis, right? What are the point in time? What is the population exactly that you're looking at? And decomposing all the variables, right? And making sure you also align on terms, right? When we do data, a lot goes with data definition, right? What do you call a case? What do you call a contact? What is a contact that turned into a case? You look at a given time frame, that if this happened within 7 days, it's different whether it happened in 14 days, right? So again, being specific on those definitions, having long dialogues, right? Sometimes long meetings, just to go back to the raw data and look at the numbers and how they add up. That's how you build trust. It's making sure that first you're comparing apples to apples, and that your numbers are matching.
creating a very detailed story with the data, from understanding with that.
Yeah.
That's wonderful. So we've got a minute left, and I want to thank you both, Ajali and Max. It's been a great presentation. I really love you guys' insights. And Stephen, thanks for providing a couple of questions there. And I really hope everyone kind of got something away from this presentation. So if you guys have any additional questions for our speakers, please contact them through the Opto app or website. Also, throw in a little survey to get some feedback on how the presentation was, on what you liked, what you didn't like, and what you thought we did a great job with, right? So please take your time to the survey, get some feedback on that, right? And again, guys, thank you for joining DataCon LA 2021. Have a wonderful day and enjoy the last session of the day. So we'll see you guys again.
Thanks,
Thank
everyone.
Thank you all.
Thanks.
Non, j'arrive pas. Ouais.